Hi everyone. So my name is Shraman Felice. I'm a lecturer at the University of Edinburgh. The past 10 years I've been working mostly on community participation in health. I'm a member of the WHO Health Systems Governance Collaborative. Been active doing different projects, including a new project on mapping the governance of the COVID-19 response. So today I'm very pleased to have a chat with Amina Jama Mahmood from Somalia. Amina, maybe you just start to introduce yourself.
Thank you very much, GB. As you said, my name is Amina Jama Mahmood, and I currently work in Somalia, or I've been working in Somalia for the last 5 years. I am a diaspora returnee, so I'm from Sweden, so where I still have my attaché. I still have my family there. So I'm a researcher at Uppsala University. I'm currently working as a project director at Save the Children International, and I am a senior gender advisor at Sidra Institute, which is a local think tank in Somalia. Thank you for having me.
Great. So in the past few months, we've been in touch a lot, trying to work together also with partners in South Africa and Kenya and Burundi and the DRC on this project that is essentially trying to figure out who is doing what in the COVID-19 response and across African countries. We're really trying to look at the governance of it. And I think it was really tough. I think it was a really hard work. And it's not something we anticipated. I think we thought there would be, finding the right contacts who would just tell us what's going on. And we had a good team of people who really know the context. And yourself, I mean, now you're extremely well connected, but yet it was really hard. So I don't know, what do you make of that experience? Why do you think it was so hard to get the data, to simply figure out what's going on?
I think it's more of politicization of academics and the fear of countries to share the information. So what was publicly, the information that was public did not correspond to what was the reality. So I think a certain fear of repercussions for politicians, but also there was a power struggle between the different key ministries and the issue of who owns the public health question, because that's what it came down to. Yeah.
And yeah, so my sense when I look at what we did is that, yeah, as you said, I think there's this tension between who officially owns public health, which is in most countries, we happily tell it's everyone, it's just nice collaborative efforts. And with the COVID-19 crisis, we see this space kind of shrink very quickly, and just very quickly, just a few people. And I don't know, I'm a bit torn, because I think on the one hand, we have seen with the COVID-19 response, people getting involved in health who normally not getting involved. Some ministries that are usually quite disconnected from health are kind of jumping on board. But my feeling is that also we've seen the exclusion of people, of ministries from the core decision on health. I don't know if that's something that you also noticed.
Absolutely. I think that was the case. And I know in the case of Somalia, the Ministry of Health, who are actually the primary owners, structurally, when you look at the governance of health, were kind of sidelined. So and you had the Prime Minister's office climbing forth and actually taking charge of the governance of the epidemics. And I think that also kind of talks to the structure of the health within a country, and what happens to when you have these shocks that are unprecedentable, that are unexpected.
Mm-hmm. And so obviously I mean, you work in a context that's often seen as really hard, and it is really hard, and often described as a state of permanent crisis. And I don't, what did COVID-19 do in a context like yours? Was it, how unprecedented was it, as would be my question, when you are, in the context of Somalia, but also other African contexts where you have, it seems that you have like crisis after crisis. Is this really the big one? Is it really like the big shock it is maybe in countries in Western Europe?
I think one of the things that we could see, at least for Somalia and Djibouti, that I was also looking at, is that the structures that have been built for years. We've had working groups. So we have we have pillars, the social pillars, and then we have the economic pillars that brings together NGOs and government bodies and interministerial collaboration. And then you had the mainstreaming of gender and all these beautiful documents that were actually developed over the years. And all of a sudden you have an epidemic and all that falls apart. And we have to build a new system, not taking into account what is already existing. And I think that has been the experience. And in a way, we kind of lose that, or have lost the experience and the structures that were put in place, as well as the competencies that were built over the years to be able to absorb these shocks. Because for Somalia, which is a fragile country, there are structures that have been put in place to absorb these shocks. They're not well built, but nevertheless, we don't have to start from scratch every time something happens. And I think that this is what happened. And sidelining of the professional bodies, for example, the civil societies and so on. So that is, I think, what really happened.
Yeah, that's a really interesting point, right? Is how, what are the ways for these bodies that have been kind of relatively peripheral, at least to the core of the decision making in the COVID-19 response? What is the, how do we reinvent new ways of engaging and new ways of being inclusive and collaborative? Because I think we all agree that's the only way to move towards universal health coverage. And I was struck to see in a sort of countries, the legal channel still works, right? And it seems that once you've lost access to your working group, or you've lost access to your ministry, to some sort of direct contact, you can still use the law and challenge what's going on. Not necessarily challenge the exact measures that are taken, although that's something we've seen in some countries, but challenge the way decisions are made and say decisions should be more transparent. And I think there was the case in Malawi, where we saw civil society actually challenge what's going on. But in terms of very concrete ideas to move forward, I don't know. What do you think about it? What do you think would be the concrete path to rebuild um, systems that are generally inclusive in their governance?
Mm-hmm. I think that's an interesting question, and that has been the discussion that has been going on globally on how do we build systems better, and we have an opportunity right now, and I think the whole idea of stakeholders, because unfortunately, when we have when we are building work groups and we are talking in terms of the health system, what consists of a health system? The civil societies do not have a clear role in the health system. So despite the fact that we know that public health cannot be the relegated to health services only, or health facilities, it has to be broader than that. So how do we then channel legally and make civil societies a substantial part of health system, and not for my experience has been, and when I was working with the health sector strategy for Somalia, we went around in different regions and for consultation purposes to look at how can we build a better health system and get inputs from all stakeholders. And in each place that we visited, the civil societies were not represented. So we had health workers. And that, in essence, kind of narrows down, especially in developing countries where we know most people don't have channels. If you have a strong civil society, then that's good. Like in Malawi, you hear their voices. There's a way to channel the voices. But then in Somalia, you don't have that. Because all this social system have been disintegrated. They do not exist. So how do we need to build structures that will include the voices, and not only include but mainstream? We talk about gender mainstreaming, for example. We talk about people with disabilities. We talk about most of the vulnerable groups, IDPs. But then how do we go from word to actually action in making them part of stakeholders who can feed in with their expertise to or how we do our programming to fit into our policies. And for that, we need to create, I think, whether it's forum, structures that really take into consideration the vulnerable communities and the expertise on the ground.
I agree with you. At the same time, I kind of have this feeling of deja vu and this feeling that this is what's been going on for so. Not actually what has been going on, but what the discourse has been for so long, and so it's really hard. I'm kind of wondering how do we make this actually happen? And I just wanted to go back to what you said earlier on, I think, traditional professional bodies, and I think that's a really excellent point, actually, that a lot of I have the feeling that a lot of health policy tends to be happening without that much of the professional bodies, or at least if you look at nurses and midwives. Maybe doctors are always a bit different, right? They're a corporation, they are usually quite well established. But it struck me in the work that we did on the mapping the governance response that, nurses and midwives, really the bulk of the workforce which I think in some cases could be a way to relay the voice um, of of the patients and the most vulnerable, because they work so closely with them. And I'm wondering whether that might not be a way to move forward, have, in a sense, it's going to sound a bit odd, but have more ownership of the nurses and midwives of the health system, so to speak. So not only ownership of their own health facility and what's going on there, that's been the sort of the mantra of community participation for years, and it works well and less well in some places, but really ownership of the whole system. I don't know if that's something that makes sense to you.
I think it does. It does really. And I think WHO and Dr. Tedros have been on the forefront and trying to create visibility for the nurses and midwives. And I think that should translate into actions on the ground. So every country actually adopts what the headquarters have created, because that's not the case. We have a lot of lip services, and especially I work as the founder of Women in Global Health Somalia. I work with the Midwives Association and the Nurses Association. And what we have seen, and we've been voicing this, we've been very verbal about the inclusion of nurses in these decision-making bodies and the task forces. So it's like even the governing bodies internationally, WHO, UNICEF, and all the UN bodies that could drive these issues are not driving it really well. So it needs to reach at country level. We need to diversify the workers, the workforce, even in organization. I talk about it in my own organization. We talk about the diversification, not only of gender, but also representation of people from the southern continent. Also what is being referred to as decolonization of global health. And so diversity, we know that by excluding professional bodies, yes, mainly female-led professional bodies, but also diversification of the different voices on the ground, the disabled people, people of color, people, local people in the organization. So I think that is also something that we need to drive. And I'm actually extremely happy to see that the world has focused its attention on the female world leaders, like New Zealand, for example, Angela Merkel in Germany, as being the best in actually handling the crisis. And that has to translate then into action at the country level.
Yeah, I think there's a real risk, as you point out, right, that we just pay lip service to gender and we say these women are empowered, they're doing so well at tackling the crisis, but then we just carry on with business as usual. And I think one of the ways forward is what we see organized from the ground and paying more attention to that and really opening our eyes to what's happening on the ground rather than always looking at the top. I mean, it's great that we have these women at the top doing well. Don't get me wrong, very happy with that. But I think there are also dynamics changing in the field, and we can get responses from there if we pay enough attention. And maybe for once we can use social media, we can put social media to good use. And I think you have, actually in Somalia, you've got some nice examples of that, don't you?
Right now, we have a group of very young midwives and nurses who are very verbal, who are what do you call it, savvy in using social media. So in a way, they've been able to create their own platform and change. Like we demanded to have gender segregated data in Somalia through Women in Global Health and the professional bodies. But then when you have the IDPs now, who, by the way, in my own project in Save the Children, we are trying to create demand for health services. And not only in Somalia, I think Sudan as well. We've seen examples of where they kind of forced changes within the task group and what was coming out of the task group, as well as reverse some of the some of the measures that were put across that were restricting against women and restricting against livelihoods. So yes, but to have somebody who's electronically, savvy enough to use the social media, that is one way. But I think there's also what needs to be done is these organizations need to be funded. It's very hard for local organization, period, to get funding because of the demands that are put in places. But it's even harder for female-led organizations or women's only organizations to get funding. So I often joke with my colleagues in Sweden, for example, or Women in Global Health in Western countries, where they say, oh, we want to have representations in panels. We want to have representation in, so that we can have a voice. And I say, I mean, for us right now, it's not in Somalia, it's not even about the panels. And we don't want to be given voice. So you can't have different measures for different countries. In Somalia, the women have a voice. The women are making demands. It's just that they don't have the resources. They don't have the platform in which to have an impact in. So partnering with women's organizations, professional bodies like the nurses and the midwives, really partnership, authentic partnership, and not having them implement ideas that have been imported. And that is very, very important to have them as experts of their own causes, of the government, of the processes that are national, because they know the issues. The problem is they don't have the platform and they don't have the resources. So, so I think that is one concrete measure that can be done.
We have to look a bit inwards. I mean, talking from my position, we have to be, being a white Western male in a Western institution, that's, it's not easy to do it here. I think there is a lot of, again, there's a lot of people saying we should decolonize the academia and we should do things differently. But then when it comes to doing it in practice, changing the way we do contracts with people, changing the way we respond to big funding calls, changing actually the way these calls are announced. To me, there's quite a lot of work to do there as well.
I just wanted to mention that we talk about accountability a lot, and trust me, I'm also in a position of privilege, having grown up in Sweden, having my Western education. So there are a lot of things that I need to think about when I'm working in Somalia, despite the fact that I very much look like a Somali, but I have different experiences. So it's something that we need to learn and take that into consideration. So yeah, if we want to have accountability and ethics in all the programs that we do, then we need to practice that individually, but also within the organizations. Actually act on those ethical structures and that we so believe in. But then somehow when we come to third world countries and developing countries, it's like we have another set of ethics.
I'm wondering whether that might not be the final word. I actually would be happy with this as a final word. It's quite a big task to just have the ethics that we claim to have wherever we are. I think that's maybe one way to push for universal coverage. Thank you so much, Amina, for this.
Thank you.
Always a pleasure to discuss with you.